Here we utilize Glidewell's digital treatment planning services, and the following is a recording of the web-based teleconference that was conducted to review the digital plan. This simplifies the process in making sure that we're able to visually determine the position of our dental implants prior to any surgical intervention.
Hello, Dr. Kaczynski.
Hi, how are you doing?
Good. I wanted to welcome you to our first WebEx we're doing together. You're an old friend and a very experienced implantologist, so I don't need to obviously tell you anything about how to place implants, but what I wanted to do is just go through with you the views we have with the Implant software.
Yes.
And we had tentatively dropped in the implants where you had requested them, and then what we can do is go ahead and change those per your recommendation, since you're ultimately going to be the one placing the implants. So just to walk through the screens real quickly for those people listening that aren't familiar with the software, this is Implant, and the implant that you requested is Cybron, and I believe that your request was you're going to put Octa on one side and a Hex on another, just for educational purposes to show the differences in how you take impressions, but the implants themselves will be identical.
Correct.
Okay, so just to walk around the horn here, on the bottom right you can see a three-dimensional rendering of the case. It's obviously a maxillary case, and looking at replacing maxillary first molars bilaterally. And then, so what we have done is segmented the case, and you can see that, and we'll go ahead and blow that view up. We can change the transparency of the bone. In this view, you can see the patient's maxilla. You can see where the teeth are. And then you can also start to make out the sinus. And then what we can also do in this view is we can show and hide things. So if you just wanted to see where the teeth are in relationship to where your implant's going to be, we can remove the bone. And we can look at things at all different types of directions. The other thing we've done here, since this case was scanned without a scan appliance, we have dropped in virtual teeth. Pretty straightforward, since obviously they just go in between the teeth, the adjacent teeth. Just gives us a better idea of how to plan it restoratively. Okay. So that's the three-dimensional rendering. If you go above it is the axial view, and we move this scroll bar, we can move up and down the axial slices. And obviously one of the first things that pops out in the axial slice, and I'm sure you're well aware of, is some kind of a pathology in the sinus. It looks like most likely a polyp or mucocele. And so it looks like you have a pretty large polyp on the patient's right side and a thickening of membrane on the right side. And go ahead and feel free to interject or jump in there, Tim.
You bet.
As we go through this, then over on the upper left is a cross-sectional slice, and if you see this yellow line that follows along the arch of the maxilla, you can see the blue line. That's what you're seeing here. So you see we can move that cross-sectional slice around. So right now we're looking in the area of number 3. And then the bottom left is a panoramic view. Okay, and again, this is a good view to show how there's your mucocele, or potential mucocele, and then you can see over here the thickening of the membrane on the patient's left side. Okay, we'll go from there. Let's start with number 3, and Tim, let you take it from there as far as what you want to do with this. Right now we had left it just short of the sinus, or a little bit into the sinus, and you can give us your 2 cents on how you would treat this case.
Well, one of the issues that we have in the posterior maxilla, obviously, is the large sinuses. Living in Michigan here, we have a lot of patients that have very large sinuses. And our concern is, can we actually place implants? Do we have the quality and quantity of bone that we need to predictably place an implant, a long enough implant? And with CTs, we're now able to measure the amount of bone that we have in 3 dimensions. And what's most important is taking it one step further in a case like this, is taking a software program like Implant and being able to virtually place the implant prior to ever touching the patient is a tremendous advantage for me. So rather than guessing or hoping that I can get an implant in the proper position, I'm going to know exactly, precisely where I want to place the implant, and if I'm able to indeed place the implant without doing more invasive procedures, such as a true sinus elevation or sinus augmentation. So in this situation, using this implant software, we're able to take our implant, we measure the amount of bone that we have, and we see that we have approximately 9 millimeters of bone to the true floor of the sinus. In the number 3 area, we do have some pathology there that we're not exactly sure what it is, but we can gather it's some kind of a mucocele or polyp. And what my intent is to always try to put the longest, fattest implant we can in any individual situation, obviously being very conscious or very aware of the prosthetic limitations. Our crown and root ratio has to be positive enough so that we don't overstress the area. In the maxilla, our major concern is that we just don't have great quality of bone. Nobody does. The bone is light, it's porous, and we have to deal with that. So again, we always want to use the longest, fattest implant. Using a tapered implant, such as this Cybron design, does give us an advantage in that we're not going to perforate and place the implant into the sinus. We would have to make a huge mistake to do that. So using the software, I'm looking at the floor of the sinus, the floor, and we can actually lift that membrane up. I feel comfortable lifting it up to 3 millimeters. So placing a 9 millimeter implant in that area really is not invasive. We're not going to perforate the sinus membrane, and even if we did, I wouldn't be overly concerned if it's a small opening. But I would feel very comfortable. We have great buccal lingual width, and we have adequate mesial and distal width. Our concern is our height of bone that we need to work with. Mm-hmm. So again, using the software, we're able to determine that we do have adequate bone to place the proper implant in the proper position.
Okay, so right now, if we look at our list of implants, we have 4.8 by 9. If we went into Cybron and we looked at the next longest implant, just to give you an idea from a virtual standpoint, it's easy to do things virtually. That's the beauty of this. If we go into Cybron, okay, our next longest implant would be an 11, and let me just show you that. Okay, so now you're definitely making more of a jump. So I guess the question I have for you would be: would you either stay with the 9 and do a little bit of a bump, or getting a little more invasive when you have to go into a little bit longer implant?
Knowing that we do have some pathology in that area, the decision was made to put a 9 millimeter implant in. What I'm trying to virtually determine is to keep the implant away from the natural teeth. I want them at least 2 millimeters away from the adjacent teeth. We have plenty of mesial distal width, so that's not really a concern at all, but we can measure that. Buccal lingually, we're pretty much in the center of the ridge. We want our forces to be down the long axis of the implant, so we can really ideally place that implant pretty much center in the ridge. If we didn't want a surgical guide, we could pretty much eyeball these situations, or we could create a surgical guide and do it that way.